Diane was not a woman who complained. She was 66 years old, retired school principal, sharp, organized, disciplined, the kind of person who had spent 40 years solving other people's problems and had very little patience for her own. So when she started waking up every morning with a dry, sticky mouth and a throat that felt like it had been lined with sandpaper overnight, she did what she always did with minor inconveniences. She ignored it. She kept a glass of water on her nightstand. She started chewing sugar-free gum in the mornings. She mentioned it to her husband once and then never again. It was not pain. It was not dramatic. It was just a dry mouth, an annoyance, something that happened to people as they got older. She assumed it would go away on its own. It did not go away. It got worse. But Diane was busy. She had grandchildren to look after, a garden to tend, a book club that met on Thursdays. A dry mouth was not going to slow her down. 6 months passed. Then one morning Diane woke up and could not get out of bed. Not because she was in pain, not because she had fallen. She simply did not have the strength. Her heart was racing in a way that frightened her. Her head was spinning. Her husband found her sitting on the edge of the mattress, unable to stand, grey-faced and confused. He called an ambulance. In the emergency room, the attending physician ran a panel of tests. Then he called the cardiologist on duty. Then he called her internist. Then he stood at her bedside and told her something that made the room go quiet. The dry mouth Diane had been ignoring every morning for 6 months had not been a minor annoyance. It had been her body sending an emergency signal that something was seriously, dangerously wrong, and it had nearly killed her before anyone listened. Who is talking to you today? My name is Dr. James Harlow. I have been practicing internal medicine for 10 years, specializing in cardiovascular and metabolic health in adults over 50. I want to tell you something directly at the start of this video. The human body does not waste signals. Every symptom, every sensation that feels out of the ordinary, every change in how your body feels in the morning, every pattern that persists beyond a few days, is communication. It is your body attempting to tell you something through the only language it has. We are taught, especially as we get older, to dismiss symptoms that are not severe, to normalize discomfort, to assume that tiredness, dryness, fogginess, and minor physical changes are simply the price of aging. We are taught to push through. Diane had spent 6 months pushing through a signal that her cardiovascular system, her endocrine system, and her autonomic nervous system were all sending simultaneously. By the time she stopped pushing through, the damage was significant. What I am going to share in this video is not meant to make you anxious about every physical sensation you experience. It is meant to give you the specific knowledge to recognize when a symptom that seems trivial is actually a red flag, and which red flags in adults over 60 require immediate attention rather than patient waiting. Dry mouth every morning is one of those symptoms, and the conditions it can signal in older adults are more serious, more numerous, and more treatable when caught early than most people realize. Stay with me through the entire video, because what Diane's story reveals about what is happening inside aging bodies while people sleep is something every adult over 60 needs to understand. Diane's story, the 6 months nobody knew about. Let me tell you the full picture of what was happening with Diane during those 6 months, because understanding her complete story is what makes the medical reality clear. Diane had been diagnosed with type 2 diabetes 3 years before this episode. Her blood sugar was managed with oral medication, and she had been told it was reasonably controlled. She had no history of heart disease, no history of high blood pressure beyond borderline readings at annual checkups. She took a statin for mildly elevated cholesterol. She was, by the standards of most routine medicine, a stable and well-managed patient. What her routine medicine had not detected was the slow, progressive deterioration happening during her sleep. The dry mouth had started gradually. The first few times she noticed it, she assumed she had simply slept with her mouth open. Her husband confirmed she sometimes snored lightly. She had always been a restless sleeper. None of this seemed alarming. But over the weeks that followed, the dryness became more consistent. Every morning without fail, not just mild dryness, but a thick, sticky sensation, a mouth that felt glued together, a throat that was raw in a way that took an hour and several glasses of water to fully resolve. Some mornings she had a headache that sat behind her eyes. Some mornings she felt a fatigue that seemed disproportionate to the hours she had spent in bed. She noticed her heart seemed to race occasionally when she first stood up. She attributed this to getting older. She noticed she was urinating more frequently at night, 2, sometimes 3 times. She attributed this to her age and to her diabetes. She noticed her concentration was not as sharp as it had been. She attributed this to stress. Every symptom had an explanation that did not require a doctor visit. And so for 6 months, Diane explained away a constellation of symptoms that her body was producing together, not separately. A constellation that read correctly, pointed unambiguously to a condition that was placing her cardiovascular system under enormous and escalating stress every single night she slept. When the emergency room physician looked at her test results that morning, he was not surprised by what he found. He was surprised it had taken this long for something serious to happen. What was actually happening? Diane had severe obstructive sleep apnea. Not mild, not moderate, severe. Her overnight oxygen monitoring in the hospital showed that her blood oxygen saturation had been dropping below 80% multiple times per night, levels associated with acute cardiac stress, arrhythmia risk, and neurological damage. In healthy adults, blood oxygen stays above 95% during sleep. Diane's had been crashing repeatedly, every night, for months, possibly years. During each apnea event, Diane's airway collapsed completely. She stopped breathing, her blood oxygen plummeted, her body responded with a surge of adrenaline that forced her to partially rouse, restoring muscle tone to her airway just enough to take a breath. Her heart raced, her blood pressure spiked, her sympathetic nervous system fired at maximum intensity. Then the cycle began again, sometimes dozens of times per hour. She remembered none of this. She was never fully conscious during these episodes. She simply experienced the cumulative aftermath every morning. The dry, raw mouth from breathing through an open airway all night, the headache from accumulated carbon dioxide, the fatigue from sleep, so fractured and oxygen deprived that it provided almost no recovery value. The racing heart when she stood, because her cardiovascular system was already operating in a state of chronic stress. What the cardiologist found that morning in the emergency room was an abnormal heart rhythm, atrial fibrillation. Her heart had developed an irregular electrical pattern. Not that morning. The evidence suggested it had been developing over months of repeated overnight oxygen deprivation and adrenaline surging. Her untreated sleep apnea had been systematically damaging her heart's electrical system, one night at a time. Atrial fibrillation is the most common serious cardiac arrhythmia. It multiplies stroke risk by 5 times. It significantly increases the risk of heart failure. And it is, in a staggering proportion of cases, studies suggest up to 50%, directly caused or exacerbated by untreated obstructive sleep apnea. Diane had been walking around for 6 months with advancing atrial fibrillation, with a dry mouth every morning, as the one visible signal. She had been 6 months away from a stroke, the science your doctor never explained. Number 1. What obstructive sleep apnea actually does to the body every night. Most people think of sleep apnea as a snoring problem, a nuisance, something that bothers your partner more than it endangers you. This understanding is dangerously incomplete. Obstructive sleep apnea occurs when the muscles of the upper airway relax during sleep, and the soft tissue at the back of the throat collapses inward, partially or completely blocking the airway. When the airway is completely blocked, breathing stops. The technical term for one of these events is an apnea. When breathing is partially obstructed and reduced but not completely stopped, it is called a hypopnea. In mild sleep apnea, these events occur 5 to 15 times per hour. In moderate apnea, 15 to 30 times. In severe apnea, Diane's category, more than 30 times per hour. In some patients, breathing is interrupted 60, 70, or more times every single hour of sleep. Each time breathing stops, oxygen levels in the blood begin to fall. The brain monitors this fall, and when oxygen drops sufficiently, it triggers an arousal response, a brief activation that restores airway muscle tone. The person gasps or shifts, airway reopens, breathing resumes, oxygen partially recovers. The cycle begins again with the next sleep stage. From the inside of the body, each of these cycles looks like a small emergency. The sympathetic nervous system fires, adrenaline surges, heart rate accelerates, blood pressure spikes, sometimes by 20 to 40 millimeters of mercury, in a matter of seconds. The heart is forced to work harder, the blood vessels are forced to constrict, inflammatory markers are released into the bloodstream. Multiply this by 30 or more times per hour, multiply by 7 or 8 hours of sleep, multiply by 6 months of nights. Diane's cardiovascular system had endured thousands upon thousands of these stress cycles while she slept, without her knowing, without her feeling it, with nothing but a dry mouth every morning to show for it. Number 2. The dry mouth signal and why it matters. Dry mouth, medically called xerostomia, is one of the most consistently reported morning symptoms in adults with undiagnosed sleep apnea. It is also one of the most consistently dismissed. The mechanism is direct. When the airway becomes obstructed during sleep, the body shifts breathing to the mouth. Prolonged mouth breathing during sleep bypasses the nose's natural humidification system and dries the oral mucosa, the mucous membranes lining the mouth and throat. The result is the sticky, raw, parched sensation that Diane experienced every morning. A persistent dry mouth every morning that does not resolve quickly with water, that is accompanied by morning headaches, excessive daytime fatigue, or waking unrefreshed regardless of hours slept, is a pattern that should trigger immediate investigation for sleep apnea, particularly in adults over 60. But dry mouth in older adults can also signal several other serious conditions that are frequently underdiagnosed and that overlap and compound each other in complex ways. Chronic dry mouth is a recognized early symptom of uncontrolled or poorly controlled diabetes, where elevated blood sugar impairs the salivary glands and promotes osmotic dehydration. It is a symptom of hypothyroidism, underactive thyroid, which is extraordinarily common in women over 60 and which produces a broad, subtle constellation of symptoms that are routinely dismissed as aging. It is a symptom of Sjogren's syndrome, an autoimmune condition affecting moisture-producing glands that disproportionately affects women over 50. It is a side effect of dozens of commonly prescribed medications, including antidepressants, antihistamines, diuretics, beta blockers, and ACE inhibitors, drugs that millions of older adults take daily. And critically, each of these conditions, sleep apnea, diabetes, hypothyroidism, autoimmune disease, can exist simultaneously and interact in ways that amplify the risk of the others. Diane had diabetes, she had sleep apnea, she had borderline thyroid function that had never been treated. Each one was making the others worse. Every one of these conditions had been whispering to her every morning through a dry mouth. Number 3. Sleep apnea and the heart, a connection that should terrify every adult over 60. The relationship between obstructive sleep apnea and cardiovascular disease is one of the most well-established and most underappreciated connections in all of medicine. Sleep apnea is an independent risk factor for hypertension, separate from weight, age, diet, or any other variable. Studies show that adults with untreated moderate to severe sleep apnea are 3 times more likely to develop hypertension than those without it. The mechanism is the repeated overnight blood pressure surging described earlier, which over months and years produces structural changes in the blood vessel walls and a chronically elevated baseline blood pressure that medication alone struggles to control. Sleep apnea is an independent risk factor for atrial fibrillation, as Diane discovered. The repeated oxygen deprivation, adrenaline surging, and pressure changes in the chest during apnea events subject the heart's electrical conduction system to repeated mechanical and chemical stress. The atria, the upper chambers of the heart, stretch and remodel. The electrical pathways that coordinate the heartbeat become disrupted. Atrial fibrillation develops. Research from the Mayo Clinic and multiple major academic medical centers has found that adults with untreated sleep apnea have a 2 to 4 times higher risk of developing atrial fibrillation than those with treated or absent sleep apnea. More importantly, studies have shown that treating sleep apnea reduces the recurrence rate of atrial fibrillation after cardioversion or ablation by up to 40%. The arrhythmia cannot be fully managed if the underlying sleep disorder driving it remains untreated. Sleep apnea is independently associated with increased risk of heart attack, heart failure, stroke, and sudden cardiac death during sleep. In patients with coronary artery disease, untreated sleep apnea significantly worsens prognosis. In patients with heart failure, sleep apnea present in up to 50% of heart failure patients dramatically worsens outcomes. Diane had been sleeping with a condition that was quietly dismantling her heart for months. The dry mouth was the only morning visible evidence of what was happening in the dark. Number 4. The oxygen deprivation brain effect. Nobody warns you about. The brain is the most oxygen-dependent organ in the human body. At rest, it consumes approximately 20% of the body's total oxygen supply, despite representing only 2% of body weight. It has essentially no oxygen reserve. When oxygen delivery drops, brain function degrades within seconds. When it drops substantially and repeatedly over months of nightly apnea events, the consequences accumulate in ways that are only now being fully understood. Chronic intermittent hypoxia, the pattern of repeated oxygen drops that characterizes sleep apnea, causes measurable structural and functional changes in the brain. Studies using MRI imaging have found reduced gray matter volume in specific brain regions in adults with untreated sleep apnea compared to matched controls. The hippocampus, the brain's primary memory consolidation center, is among the most affected regions. The cognitive consequences of untreated sleep apnea in adults over 60 are now recognized as a significant and underappreciated contributor to what is commonly diagnosed as age-related cognitive decline. Memory impairment, difficulty concentrating, slowed processing speed, and executive function deficits, the same symptoms routinely attributed to normal aging, are frequently found to improve substantially when sleep apnea is identified and treated. A landmark study published in the Journal of the American Medical Association found that adults with untreated sleep apnea developed mild cognitive impairment and Alzheimer's disease at an average of nearly 10 years earlier than those without sleep apnea. 10 years. From a condition that produces a dry mouth every morning, Diane had been noticing that her concentration was not as sharp as it once was. Her word finding was occasionally slower. She had attributed it to getting older. It was her brain responding to months of nightly oxygen deprivation. Number 5. Uncontrolled diabetes and sleep apnea, the deadly partnership. Diane had type 2 diabetes. She also had severe sleep apnea. These two conditions do not simply coexist. They actively worsen each other through a series of interlocking biological mechanisms that create a cycle of deterioration that neither treatment alone can fully break. Sleep apnea causes intermittent hypoxia. Intermittent hypoxia activates the sympathetic nervous system and triggers cortisol release. Elevated cortisol directly causes insulin resistance. It signals the body to release glucose into the bloodstream for the fight or flight response it believes is occurring. In a person who already has impaired insulin function, this produces significant blood sugar elevation during and after each apnea event. Studies using continuous glucose monitoring in diabetic patients with sleep apnea have documented substantial overnight blood sugar spikes corresponding directly to apnea episodes. The elevated blood sugar then impairs the immune response, worsens inflammation, promotes further nerve damage, and makes the cardiovascular consequences of each apnea event more damaging. Morning blood sugar in poorly controlled diabetics with undiagnosed sleep apnea is frequently elevated, not because of what they ate the night before, but because of what happened while they slept. Meanwhile, diabetes impairs the nerves and muscles of the upper airway, making airway collapse during sleep more likely and more severe. It promotes the central obesity pattern, accumulation of fat around the neck and abdomen that mechanically worsens sleep apnea, and it impairs the brain's arousal response to hypoxia, meaning diabetic patients with sleep apnea are sometimes slower to rouse from apnea events and experience longer duration oxygen drops. Diane's diabetes and her sleep apnea had been locked in this cycle for years, each one making the other worse, neither one being addressed in relation to the other. Her medication managing her blood sugar numbers in the daytime, while overnight, entirely unseen, the cycle continued. Number 6. The medications that make dry mouth and sleep apnea worse. This is something I want every adult over 60 watching this video to understand clearly and to check for themselves. A significant proportion of commonly prescribed medications make both dry mouth and sleep apnea worse, not as rare side effects, as documented, expected pharmacological consequences. Muscle relaxants, benzodiazepines, and sleep aids, including commonly used over-the-counter sleep medications containing diphenhydramine, relax the muscles of the upper airway and directly worsen obstructive sleep apnea. Many older adults take these medications specifically because their sleep is poor. Their poor sleep is often caused by undiagnosed sleep apnea. The medication they take to address their poor sleep makes the underlying cause of that poor sleep more severe. Anticholinergic medications, a class that includes certain antihistamines, bladder medications, antidepressants, and antipsychotics, suppress salivary gland function and cause dry mouth as a primary pharmacological effect. Anticholinergic burden, the cumulative anticholinergic effect of multiple medications taken simultaneously, is a recognized syndrome in older adults associated with cognitive impairment, fall risk, and cardiovascular complications. Diuretics taken by millions of older adults for blood pressure and heart failure reduce total body fluid volume and can cause or worsen dry mouth, particularly when taken in the evening. Diane was taking a statin and a diabetes medication. Neither of these causes significant dry mouth, but her pharmacist had recently added a low-dose antihistamine for seasonal allergies that she had been taking every evening. This medication was suppressing her salivary glands overnight and worsening the dry mouth symptom that was already present from her sleep apnea. It was also relaxing her upper airway muscles, worsening the apnea events. A simple medication review, looking at every drug for its contribution to her symptom pattern, was something nobody had done for 6 months. Number 7. The test that should have been done on day 1. The diagnosis of obstructive sleep apnea requires a sleep study. This used to mean an overnight stay in a sleep laboratory, inconvenient, expensive, and intimidating enough that many patients deferred or refused it. That is no longer the only option. Home sleep testing, a simplified sleep monitoring device that the patient wears at home for 1 or 2 nights, is now widely available, covered by Medicare and most private insurance when indicated, and accurate enough for the diagnosis of moderate to severe obstructive sleep apnea. It measures breathing effort, airflow, blood oxygen levels, and heart rate. The device is small, attaches simply, and requires no technician to administer. For Diane, a home sleep test ordered at her first mention of morning dry mouth and fatigue, or at any point during the 6 months of symptoms, would have identified her severe sleep apnea with certainty. Treatment could have begun within weeks. The months of progressive cardiac damage, the development of atrial fibrillation, the cardiovascular crisis that landed her in the emergency room, all of this was preventable. The threshold for ordering a sleep study in adults over 60 who report persistent morning dry mouth, unrefreshing sleep, daytime fatigue, witness snoring, or morning headaches should be extremely low. The test is accessible, affordable, and the consequences of missing the diagnosis, as Diane's case makes clear, can be catastrophic. If you report these symptoms to your doctor and a sleep study is not offered, ask for one by name. What happened to Diane? Diane spent 4 days in the hospital. She was cardioverted. Her heart rhythm was restored to normal using medication. She was started on a blood thinner to reduce her stroke risk from the atrial fibrillation. She underwent an in-hospital overnight sleep study that confirmed severe obstructive sleep apnea with an apnea-hypopnea index of 44 events per hour, nearly 1 event every minute she slept. She was fitted with a CPAP device before she was discharged. Continuous positive airway pressure, a machine that delivers a gentle stream of pressurized air through a mask to keep the airway open during sleep. The first morning she woke up after using the CPAP, she called her daughter before 7 in the morning. She said, "I do not know how to describe this. I slept. I actually slept. I do not remember the last time I woke up feeling like this." Her morning dry mouth was gone, completely, after 6 months of every morning beginning with that raw, sticky sandpaper sensation gone on the first night. At her 6-week follow-up, her blood sugar control had measurably improved without any change to her diabetes medication. Her blood pressure had dropped. Her cardiologist reported that her cardiac monitoring showed no recurrence of atrial fibrillation. At 3 months, her neurologist noted measurable improvement in her cognitive testing scores compared to baseline. Diane told me at that visit that she wished she had a way to give back the 6 months she had lost. The 6 months of fractured nights and exhausted mornings and a body under siege that she had spent explaining away. I told her she had something better than those 6 months. She had the rest of her life with a body that was finally, for the first time in years, actually sleeping. What you should do right now, if you wake up with a dry mouth consistently, not occasionally, but most mornings or every morning, here is what I need you to do. Do not explain it away. A persistent morning dry mouth is a symptom requiring investigation. It is not a normal part of aging. It is not automatically explained by the weather or the temperature in your bedroom. It is your body telling you something. Make an appointment with your doctor this week and describe your symptoms specifically. Tell them how long it has been happening. Tell them whether you wake unrefreshed. Tell them whether you snore or have been told you stop breathing during sleep. Tell them whether you have morning headaches. Tell them whether you are getting up multiple times at night to urinate. These symptoms together paint a picture that your doctor needs to see complete. Ask specifically about a sleep study. Use those words. Ask your doctor whether your symptoms warrant a sleep study. If the answer is no and you have multiple symptoms from the list I just described, ask again and ask why not. Home sleep testing is accessible, affordable, and covered by insurance in most cases. Bring a complete medication list to your appointment. Include every prescription, every over-the-counter medication, every supplement. Ask your doctor or pharmacist to review the list for medications that contribute to dry mouth or worsen upper airway muscle tone during sleep. If you have diabetes, understand that your blood sugar control at night may be significantly different from what your daytime readings suggest. Ask your doctor about the connection between sleep apnea and blood sugar dysregulation. If you have unexplained morning blood sugar elevations, despite good daytime management, this connection may be the explanation. If you are diagnosed with sleep apnea, treat it. CPAP therapy has a reputation among patients as uncomfortable and difficult to tolerate. Modern CPAP machines are dramatically quieter and more comfortable than earlier generations. Newer mask designs address most fit and comfort issues. The adjustment period is typically 2 to 4 weeks. The benefits, cardiovascular, metabolic, cognitive, and simply the experience of waking up rested, are transformative for most patients who persist through the adjustment. Do not wait 6 months. Do not wait 1 month. Diane's story is not rare. It is playing out in bedrooms across this country every single night in people who are waking up with dry mouths and dismissing the signal their body is working desperately to send them. Final message and call to action. Diane was not careless. She was not uninformed in any general sense. She was a sharp, educated, disciplined woman who had spent her career paying attention to things that mattered. She just did not know that a dry mouth every morning was a thing that mattered. None of us know the things we have not been told. That is why this video exists. After 60, your body's warning signals deserve respect. Not panic, not obsession, respect. The kind of respect that says, this has been happening for 6 months, and I am going to find out why. Diane survived. Her heart rhythm was restored, her sleep apnea was treated, her brain began to recover, she got her life back, but she was far closer to not getting it back than she ever knew, until she was sitting in a hospital bed on a Monday morning, 4 days after her husband called an ambulance. Here is what I want you to do today. Think about your mornings. Think about how you wake up. Do you wake up dry? Do you wake up tired, regardless of how long you slept? Do you have morning headaches? Is someone in your house, a partner, a family member, telling you that you snore or that your breathing sounds strange at night? If any of those answers is yes, call your doctor today. Not next week, today. Then watch the next video on this channel, where I walk through the complete sleep health protocol for adults over 60, everything from sleep apnea screening to sleep architecture optimization to the specific interventions that protect the aging cardiovascular system during the most vulnerable hours of the night. And share this video. Share it with the person in your life who snores. Share it with the person who is always tired no matter how much they sleep. Share it with the person who keeps a glass of water on their nightstand and reaches for it every single morning before they are even fully awake. They may not know what that dry mouth is trying to tell them. You do now. I am Dr. James Harlow. I will see you in the next one.